series of more webinars that we will be doing as part of our education, give back to our community and also all our stakeholders. So my name is Nompumelelo Makakula. I will be your host for this afternoon's exciting webinar. I am not by myself. I have the exciting duo, Tammy and Maria, that will be taking us through the curable and non-curable STIs. Like I said, this is one of many CPD approved and accredited webinars that we will be giving. The continuous professional development points, those are for our clinicians that qualify to get these. So these are your clinical associates, your nurses, and your doctors that will join us on these platforms. If you register and we get all of your information, you will then be accredited with the appropriate points for this webinar. Everybody else is still welcome to join. You will not be getting the CPD points, but you'll be getting a wealth of information that will help you through your health journey and becoming a better person. So welcome everyone. I will now hand over to Dr. Tammy and Maria to introduce themselves. Thank you.
Right. Hi. Afternoon, everyone. My name's Tammy. I'm a medical officer in the Key Populations program at Aurum. And so just a bit of background, I've spent most of my career here in South Africa and Australia focusing on sexual health. And I have a particular interest in key populations. Most of my work has been with men who have sex with men, sex workers and transgender women. And I spend a lot of time looking at the HIV treatment and prevention cascade, as well as all the sexual health indicators. So thank you, and I look forward to this afternoon.
Hi everyone, my name is Maria Sibanyoni and I'm the technical advisor here at Aurum, working with key populations, and I've been working in the public sector for more than 30 years now, and my expertise really lies in HIV management, and I've worked for many years with key populations, particularly sex workers, MSM, and transgender people. Thank you.
Okay, without further ado, over to you, Tammy. We are all ears.
Yeah, let's kickstart. Just to actually create a scene, STIs are the drivers of HIV, and if they are not treated properly, really, it puts a person in a vulnerable position. So it's very important for us, to treat STIs. And we know that they are sexually transmitted generally, but there are those that are also non-sexually transmitted, such as the ones that are transmitted during pregnancy, during childbirth, through blood transfusion, and when a person share needles. And also what we need to note is that not all the STIs are symptomatic. There are those that are also non-symptomatic, where you find a person will be walking around with STIs and not being aware that they've got STIs. You can put the first slide, Happy. Yeah, these are one of the common acute conditions, and it's really globally. Not only it affects South Africa, but it's a global public health challenge, with health, gender, and equality. And also there's also stigma and discrimination that is contributing to this high burden. And with the MSM and transgender women cohort that we are currently working in, in our key population centers, we find that there's high incidence and prevalence of STIs. And globally, the health strategy, it details the vision and the action to end STI epidemic with strategic case of management as a key priority. And management does not only include, your treatment, giving tablets to the client. It also includes health education, but most importantly, we have to treat the partner. When I was still a clinician, we used to have like a person who would give them more than 2 or 3, partner notifications to give to the partner. And they used to bring them, on different days to ensure that everyone gets treated and life goes on. Next slide, Happy. So if we look at the slide, what is it projecting here is that, over the 6 consecutive years, according to CDC, the STIs numbers have been, or cases have been increasing. And this really, what it says to us, it really says to us, it's important for us to screen people, to treat people. I know in South Africa, we treat syndromically, which is good, but also ensure that our especially our key populations have got access to health services, because with key population, we know there's discrimination, there is stigma, so they shy away from accessing healthcare services. Some of the people, they rather go and consult traditional healers, go and buy over-the-counter medication, because they can't access health services because of the stigma and the treatment that they get from healthcare providers. Next slide. Next slide, please, Happy. Yeah, looking at the OREM data that we actually projecting here, this data is for the last COP year, and we can see that majority of our STIs are male urethral syndrome, followed by syphilis, anal discharge, and we also notably we've got clients that have got hepatitis B. But what we've also noted is that, clients that are presenting with STIs in our clinics are clients that are on PrEP. And what does it say then to us is that some of the people, when they start PrEP, they might be, ignorant or lack information that, PrEP will only prevent HIV transmission, but not all other, STIs. So the emphasis really is around, if you are providing PrEP, is important for us to emphasize that people should also continue using condoms. Next slide. I think I will hand over to Temi to continue with the presentation. Thank you.
Great, thanks, Maria. So as the sort of topic of the presentation would suggest, we've gone with the WHO classification of curable and non-curable STIs. So I'm not going to read the list. You can see there. So the ones we're going to focus on is the gonorrhea, chlamydia, syphilis, the herpes simplex, and the HPV. I've left off the hepatitis B and the HIV because they, in and of themselves, are an entire webinar. So I thought I would just focus on some of the bugs that we don't normally focus on, because as Maria said, we syndromically treat. Next slide, please. Okay, so gonorrhea. I would say it's one of my favorites, but yeah. So I've put the pictures up because I do find that often it can be pictures that really help us. And I guess what I really want to kind of take home is One, if you look at the discharge, it can actually be quite diagnostic compared to something like chlamydia. It's very thick, it's very green, it's purulent. You see it in women, obviously, as well, but it can be quite distinctive. And in South Africa, we don't actually take a swab and stain it and look under the microscope. But in other countries, and I've done it, where you take the swab, you stain it, and the far right picture, those little dots are actually the gonococcus. And often you can do this with the client lying on the bed and then come back after 5 minutes and know exactly without actually testing further. But yeah, so the main thing is around the discharge and the color. Right, next slide, please. Okay, so the primary sites are the urethra, rectum, and really I've underlined the pharynx, the throat. It's not something we're all familiar with, and it's certainly not something that I think most of us think about in terms of someone having a sore throat. But the STIs, chlamydia and gonorrhea, do like living in the throat. Obviously, through oral sex, it then can be transferred to partners. So yeah, just something to know and kind of be aware about. The incubation period is 3 to 5 days, so meaning from the contact, say, with someone who has gonorrhea to when you will present will be 3 to 5 days. So if someone comes in on a Monday morning and says they had a sexual encounter and they're worried on the Sunday, it's unlikely to be presenting yet from that encounter. So as I said, the discharge is thick, green, and purulent. They also present with a dysuria because obviously the urethra is inflamed and full of infection. Anally, we get a discharge called anal leakage, can be of stool. And then, like I said, the sore throat. So the investigations, now I am talking about investigations where we would be testing for that particular STI. So we do a first void urine, and the first void is obviously because if we void first, you're going to clear the infection. So we want as much of the substance or the infective discharge to be in that urine. And then what we can also do is we take a swab. It looks like a really big earbud. Clients can do it themselves, or you can help them with it, especially with the throat. And they take a swab from the penis, the anus, and the throat for nucleic acid amplification testing. So it's just NAT testing. Basically, you amplify the DNA there to see what you have. So the management, I'm sure you all see that ceftriaxone is something we use as part of our syndromic management, and our, which bug we've included in that. So why do we use KEF? It's probably to cover the gonorrhea, as well as azithromycin. Okay, next slide, please. Okay, chlamydia. So chlamydia, the top right picture doesn't suggest that the discharge is different, but the middle two pictures, the bottom picture, you can see it's more of a clear discharge, and then the discharge on the finger is more whitish and clear. Bottom left is chlamydia in the throat. So yeah, something like I said to maybe keep in the back of your mind that potentially it's a cause. Next slide, please. Right, incubation period, 2 to 3 weeks, much longer than gonorrhea. We have that discharge, painful urine, as I said, clearer, but it's also one of those sneaky STIs that can be asymptomatic, especially in women. So we land up with fertility issues. They get pelvic inflammatory disease and can really lead to quite a lot of complications within the female anatomy. So it is one of those STIs that unfortunately has quite a big impact on women. Investigations, same as gonorrhea, we would do a urine and then the swabs. And the management is azithromycin, 1 gram, as a single dose, or doxy. So there has been emerging evidence that, in fact, chlamydia in the rectum is better treated with doxy 100 milligrams twice a day for 7 days, as opposed to just that single dose of azithromycin. Right, next slide, please. Okay, syphilis. So syphilis falls under one of the genital ulcer diseases that we see in our SOPs, our handbooks. So on the left is the actual syphilis bug, the spirochete, and then various pictures. The unfortunate person on the top right has obviously had quite severe complications from syphilis, but in and of itself, it can be something that can go unseen and that persists for a very long time. Next slide, please. Okay, so we definitely know it's a biological driver of HIV, and it's something we really need to be vigilant about. And then, of course, the long-term consequences. So you get that neurosyphilis, cardiosyphilis, which can be obviously very devastating for someone. And this is back to syphilis can be congenital or acquired. So congenital through birth, acquired in adulthood, most likely. And acquired syphilis has stages. So we have the early stages, which is your primary and secondary syphilis with an incubation period of 10 to 90 days. You then get early latent, late latent, where you're not infectious, but in terms of vertical transmission, mother to child, you are. And then you get tertiary syphilis. Next slide, please. Right, so I find like screening is something that does confuse people. So in South Africa, we do a TPHA. So if we send off for syphilis testing to the labs, they do a TPHA. If that TPHA is positive, they automatically go on and do an RPR. And an RPR will basically tell us, is the syphilis current or is the syphilis previous? So if your RPR is negative, but your TPHA is positive, it would indicate that this client at some point has had syphilis, may have been treated, may not. Often clients don't know what they were treated for, but if you generally ask, did you get an injection? Most people will know. So if the RPR is positive, like I said, if they're both positive, you have active infectious syphilis, and this is where our titers come in, which is really important to record because we do need to check if, if treatment has been effective or if there's been reinfection. Next slide, please. Okay, so early syphilis, this is the primary and the secondary. I've discussed the incubation period. So the symptoms and signs is this chancre, which can be absolutely painless. Some clients may not even know that they've had it. You can get multiple chancres, which are painful, as well as extragenital, like the mouth. And this is where, if we look at our genital ulcer disease sort of algorithm, you do cover for syphilis at the same time because we can't be 100% certain with our testing or with a lot of experience, are we dealing with herpes or this early stage syphilis? And you also get lymph node enlargement. Next slide, please. Right, so these are the chancres. The far left pictures are in fact were done with the scope, and those are the chancres in the rectum. So you won't actually see them, and the client may not know that they're there, but they are internal. And then the middle one with the arrow, it's pointing to something extremely tiny, which is again why it may completely get missed. And then we have some obvious examples of what it would look like, not forgetting anything around the mouth and lips because of oral sex, that in fact, that could be where the syphilis entered. Okay, next slide, please. So secondary syphilis, this is, if anyone's seen it, you'll know what I'm talking about. It's really obvious and diagnostic. And what you get with the secondary syphilis is this massive rash. It is generalized. It's not itchy. And then we get that there's a typo, palms of the hands and soles of the feet. You also get this patchy hair loss. You get psoriform lesions. You kind of get this prodromal sort of presentation of fever, malaise, arthralgia. Clients won't feel well. What generally obviously would bring them in is the rash, because most of us would think it was a flu or something benign like that. Right, next slide, please. Okay, so these are just pictures of secondary syphilis. You can see the hands and the feet all over the body. That client in the top right corner, obviously on the face. But once you've seen this rash once, you pretty much remember, because most people have something similar. So that's secondary syphilis. Also something to consider, you know, if someone comes in with a rash, not to always think dermatology, that STIs also can be thrown in the mix. So really important to inquire about that and to do a serology for syphilis. Right, next slide, please. Okay, so the management, I've mentioned the benzathine, benzyl penicillin. You can either give it as a single dose, and that depends on which stage and whether there's been a recent RPR result in the last 2 years, if it was positive. So normally the later stages and any recent positive result, you'll give, you know, that weekly dose for 3 consecutive weeks. But, you know, in our sort of situation, it's probably best if a client can do that to do the 3 doses. But obviously, you know, we do have challenges with clients coming back. So, yeah, 3 doses, but 1 dose, hopefully you catch them at the right stage. So penicillin, I can't remember the last time I really saw penicillin in stock at most of the clinics around. So doxycycline, 100 milligrams twice a day for 2 weeks can be used. And is mostly used now. And then just to remember that we also need to repeat that RPR in 6 months, because we do need to, again, as I said, look at reinfection. Has it worked? I personally do repeat it slightly earlier, just to see. But yeah, 6 months to see what's happening. Okay, next slide, please. So herpes, again, that's ulcer disease. So herpes simplex, so you get herpes simplex 1 and 2, can be pretty obvious. You get these sort of crops of these microvesicles. You can get this prodrome, again, of not feeling well. The area where the vesicles eventually pop up can often be quite tender because you're getting that neural pain, because herpes lives in the nerves. And in fact, if you look at genital herpes, when it goes sort of dormant before reactivation, it can live in your sacral plexus, and then it gets reactivated and travels down the nerve. So that's where that neural pain comes from. And again, not to forget around the oral region, that you can then have oral herpes simplex, have oral sex, and then someone lands up with genital herpes. Right, next slide, please. Okay, so as I said, there's 1 and 2. When we see those clients that keep coming back, we're most likely looking at 2, although like I said, we don't test, but just something to bear in mind. And incubation period, very variable. I've gone through the vesicles. It's the same pain if it's around the penis or the vagina, dysuria, you get a discharge. Interestingly enough, the first sort of time you present, you'll get this bilateral inguinal lymphadenopathy. And then at follow-up incidences, we often find that it's unilateral, and it can change from left to right. It's just whatever the virus has kind of favored in that reoccurrence. So part of the treatment, and this is something that we can certainly do aside from medication, is around the saline baths, betadine swabs. very, very important early on is to help with analgesia. It can obviously relieves a lot of the pain and can sort of diminish or halt some of the nerve damage that we can associate with herpes. So really, really important to throw in analgesia soon, high doses, with an anti-inflammatory and probably something like a paracetamol. So the management is your antivirals, acyclovir. It's quite high doses, so it's 400 milligrams 3 times a day for 10 days. The PENG would be for in case it was syphilis, and we're not sure. And then I have seen some clients, because of what's happening in the genital region around the herpes, that they get urinary retention. So they're unable to void, and then you can do catheterization. So it's not a permanent catheter, it's intermittent catheterization, and hopefully the treatment works pretty soon. Right, next slide, please. Okay, HPV. So HPV is something that it is pretty devastating. It's something I sort of gets me going a bit. So HPV, you can see a lot of examples of genital warts. I'm sure we're all quite familiar with them, and they can range from sort of pretty minor to, if you look at the far right top, I mean, those are those big cauliflower warts on the penis. So depending on clients or patients, how they present. Right, next slide, please. Okay, so the reason I kind of get a little bit up about HPV is the HPV link in cancer, and I'll come on to that in a second. So interestingly, 75 to 80% of sexually active adults have been exposed. It's very common. We don't know we have it, but only a quarter of us will ever really develop lesions or warts, and that can be due to genetics. Most people can clear it themselves and don't present anything. There are many different types of strains of HPV. HPV 6 and 11 are the genital warts HPV, which is different to the cancer-causing HPV strain. And infection is via microabrasions from genital contact. So you don't even have to have penetrative intercourse. Just merely that skin-on-skin contact, even just a bit of rubbing, can certainly spread it. So, if you think of condom usage, there's also, the HPV can be all around that area, and you can still pass it on. I'm not saying don't use a condom, definitely use it, but that can be why someone gets HPV even though they're thinking they're having safe sex. So the warts can be anywhere. For us, and we don't, sexual history and sexual health is quite a sensitive topic. I think clinicians, we don't always know how to ask, and patients are obviously very shy. It's something very personal. And, warts inside, and, the person may not know that they're there, but they'll present with something like bleeding, or maybe just around the edge of the anus, there's some small warts, and they can generally feel that. Okay, happy. I'm sorry that the pop-in thing is blocking the bottom part of the slide. So, thank you. So the management, which we don't do here, we can basically freeze them off with liquid nitrogen. We used to have podophyllin. I don't think it's on our email anymore in terms of primary healthcare, and imiquimod we don't. I mean, we'll see that in private, but certainly not in the public health sector. Right, and just a note that most of our patients or clients, in fact, won't receive any form of treatment for HPV unless the warts are very extensive and are causing severe problems for the clients. Okay, next slide, please. Okay, so my big gripe is HPV and cancer. So HPV causes the majority. Anal cancer is something in our men who have sex with men we don't spend a lot of time, and a lot of people don't generally know. The cervical cancer, we all know. That's why we do pap smears and why it's so important to do pap smears. Oropharyngeal cancer, vaginal cancer, and vulvar cancer. HPV 16 has been identified as the major oncogenic strain, so the one causing the cancer, contributing to around 56 to 73% of your anal and cervical cancers. So the anal intraepithelial neoplasia, which we wouldn't know and wouldn't test for, because we don't do sort of pap smears in the anus, but that has been associated with HPV strains 16, 18, and 31. And so obviously, I mean, we don't know what strain we're dealing with, so we don't know if it's just going to be something that will cause warts or if something more sinister could be happening, like cancer. So really, really important to be aware of HPV and cancer. Okay, next slide, please. So the vaccines, we have two. We have a quadrivalent. So the Gardasil will prevent infection for type 6 and 11, which was your warts, and 16 and 18 associated with your cancers. We have a bivalent Cervarix, which is just your 16 and 18, and that's your cancer. And our programs are for young children, and obviously it has been something of a topic of contention among parents and schools. But the vaccines are intended for prophylactic use, so before the onset of sexual activity and exposure to HPV. Does it harm someone giving them a vaccine? No, not necessarily if they've been exposed, but this is where they're most effective. So from a public health point of view, we're not just going to offer it to everyone. We are going to target a certain age group. Right. Next slide, please. So partner tracing. So Maria spoke about that. And this is, I think, can be one of the most challenging aspects of our job, and when we're looking at STIs, but is one of the most vital aspects. I've heard a lot of people say, well, if someone's exchanging, or they're in transactional sex, how are they going to know? They have all these partners. What happens generally is actually it's not the clients of sex workers. It can be their regular partners who they perhaps don't use condoms with, and who are contributing or causing the infection. So partner tracing is a must. And we also need to equip our patients with how to bring up perhaps a delicate topic. Someone may be very defensive. And it can be a huge explanation for why we see people not responding to treatment. I've done, especially I've done a few syphilis titers, and you'll see that they don't drop. You're treating, and in fact, the person has been too afraid to tell their partner in case their partner leaves them. So it's something we do need to work on, and something we absolutely need to ensure that when the client leaves our rooms, that we have at least discussed partner tracing. Right, that's it from me. So thank you very much, and I hope that was informative.
Wow, Dr. T, that was so informative. You took us back to school for a minute there. Thank you so much. We're just going to take some questions from the chat space quickly. The first one coming from the clinicians, obviously, wanting to know if they don't have penicillin, what's a suitable substitute for them to give to their patients?
For what? Yeah, So I guess we're looking at, say, the syphilis. So most of us will be using doxycycline because penicillin, there is in fact a global shortage. So doxy, 100 milligrams BD, can be for 7 days or 14 days.
Noted. Thank you very much, Doc. Another one coming from Abraham Mashabela wanting to know, is there a difference between the herpes that I find on my lips, like you were saying, those sores, and also the cold sores in terms of their presentation? Would a clinician be able to point out this is just a cold sore or this is now herpes?
So yeah, I mean, I guess the question would lie around what are we classifying as cold sores? Most people, when they talk about cold sores, in fact, are herpes. We do get these aphthous ulcers, which we don't know the cause of, and they present very commonly in people, and they've got nothing to do with herpes. But you know, the herpes virus, it's painful, it's sore, and everything tingles around it, and you don't feel great. So you know, if it's something benign like those aphthous ulcers, they'll come and go with a bit of discomfort, but you'll definitely know if you have herpes. And like I said, if you have oral herpes, to be really careful because you are infectious wherever your lips or mouth may go.
Nice. Thank you, Dr. T, for that answer. Letitia also wanting to know that apart from HPV vaccine, how can one also protect themselves? Since you did mention that it's not only through sexual contact that you can get it, you can also get it just from skin to skin contact.
Yeah, I mean that's a really relevant question, and you know we don't have a great answer. The vaccine was to hopefully decrease the amount of HPV in the sexually active pool. Most of us probably have had HPV, but we can quite easily clear it, you know, on our own. So you don't really know. It's just a small percentage of people that get the HPV that then develop the sort of
with
symptoms. Yeah.
Noted. Andila also wanting to know, are what's contagious? You did say if they're not extensive, there's no treatment necessary for them, but are they contagious?
Yeah. So I mean, I think, you know, if in our situation, being a low to middle income country, we're not going to treat if something's not extensive. And like I said, we had podophyllin, but it seems to have disappeared. So you know, in other countries, you'll freeze the small warts off, and that's also just because of aesthetics. So the warts themselves, you know, if you go and touch a wart, you're unlikely to get HPV. But what they are saying is that you have HPV, and that it's something to be aware of. Most people don't tell their partners if they even know that they have it. So yes, HPV is contagious. The warts in particular, not in and of themselves, and only if you are one of the unfortunate few that actually present with them.
Thank you, Dr. T. Final one from Funeka wanting to know, so if I'm an MSM client at the pop-in clinics and happen to have a female partner and I've now been diagnosed with STI, when you partner tracing, will you be able to treat my female partner?
Well, for HPV in particular, no, and unless there's something that's happened, like the warts, or you know, in our immunocompromised cohorts, so the HIV. Obviously, it's a huge problem with the cancers because of the state. You're unable to clear the virus as much. So the HPV, no, there isn't a treatment that we would give to a partner. It would be more the individual who has it, just to be aware that they have it. Yeah.
Noted. And keeping in the subject of partner tracing, can you just describe to us how I would know, or is it even possible, if I was now diagnosed with an STI and I do have multiple partners, can I pinpoint exactly which partner gave me the STI?
Yeah, so I mean, to some relative accuracy, so that goes around to the incubation periods that I mentioned. The difference, say, between a gonorrhea and a chlamydia. But I personally wouldn't say, if you've had multiple sexual partners within a relatively short space of time, you can't really say this is the person who gave it to me. So partner tracing is something that is particularly hard. And when I was working in Australia, they would have apps. So you could go onto an app and the app would say Tammy had syphilis, and I could go on the app during the week and check who I'd had intercourse with, as say one of the partners, and say, oh yes, I was with Tammy on the weekend, I better go get checked. So it's an anonymous way of sort of partner notification, which is not, and it was actually called the Thunder Down Under. That was the name of the app.
Wow.
Yeah. But here, unfortunately, we are reliant on our patients telling their partners, and that fabulous little slip that I'm sure half the time lands up in the trash can. When people
Yeah. Thank you so much. And to all those creatives out there, there's a great idea on an app, right? You'd keep a list of where you were this weekend and who you were with. Thank you so much, Dr. T, from that. I see Happy Palengs also come through to ask, what happens when one keeps on having repeated STIs and not completing their treatment? When they feel better, they stop.
Yeah.
But when the STI comes back again, what are the consequences for such a patient?
Yeah, I mean, basically, you're not going to clear it. It's kind of as simple as that. So if you're symptomatic, then you're going to carry on, say, having a urethral discharge. I think that's a very valid point, Happy, you bring up, that when people feel better, and most of us do, we kind of stop. I know I'm probably not the best at taking a course of antibiotics. You kind of get over it after a few days and you're feeling better. But at the end of the day, it won't go. And it also kind of goes back, and I know if I see a patient who's come in multiple times, I've given them treatment, and they are not getting better, I always you think of the partner, that they haven't disclosed, the partner hasn't been treated, and we won't go into disclosure. That's something that we all battle with in a whole nother topic. But yeah, it's definitely that reinfection cycle. So long-term consequences, sure. I mean, something like chlamydia, in females, you get that pelvic inflammatory disease. So there are certainly consequences we won't know about now, that will sort of turn up later. But yeah, we've got to get our patients finishing their course and getting their partners treated.
Very true, very true. Thank you, Dr. T. Thank you so much. Just wanting to clear up. So are you telling me that the Aurum Pop-In clinics give all this treatment that you've spoken about free of charge to all their MSM clients?
Absolutely. 100%.
Wow, nice, guys. So you hear it. If you are noticing any funny symptoms, if you're not feeling well, a bit under the weather, not knowing who you were with this weekend, just pop into one of our clinics and try and figure out what's going on. All our services are 100% free, like you've heard it from the doctor. Thank you very much, Dr. Tammy. The thank yous are starting to pour in. And definitely, guys, we will be hosting more of these. And for the clinicians, it will be CPD accredited, so you will be getting points.
Right. Thank you so much.
Thank you so much, Dr. Tammy. Like I said, very informative, very enlightening. Can't wait to have you back. The dynamic duo, Dr. Tammy and Maria Sibanyoni. Thank you so much for our STI non-curable and curable webinar.
Thank you, everyone, for listening, and I hope it was, insightful and you've gained a lot from the session. Thank you.
Thank you, everyone. See you at our next webinar. Have a good evening. Bye-bye.
Bye, everyone.